Hello, everyone, and welcome to this webinar on opioid agonist maintenance treatment as an essential health service. My name is Emma Day. I'm Executive Director of INPUD, the International Network on Health and Hepatitis and Substance Users. We are honoured to be co-hosting this webinar with WHO and Médecins du Monde and thank them for their collaboration. We also thank WHO for their leadership on the recommendations that are being put forward in the document we'll be discussing today. Some brief housekeeping before I hand over to our moderator for the session. Closed captions are available, so to turn them on, just select the CC button at the bottom of the toolbar on your screen. You can also choose translated captions by selecting your preferred language. Please use the Q&A function to submit questions. You can also upvote questions that have been submitted by other attendees. We will address questions at the end of the session once all the presenters have spoken. If we don't manage to get to all of the questions, we'll try and get answers to you where possible after the webinar. It's now my pleasure to hand over to Annette Vester, someone well known to many of you, I'm sure, and former lead on key populations and harm reduction at WHO. Thank you, Annette.
Thank you so much, Emma. I'm really happy to be chairing this webinar today. It's about one of the last documents I was engaged in. I'm very proud of it. It's a document that was developed by two departments in WHO, both the former HIV and the substance use department. And I won't talk very long, but it's a pleasure to see many of you and to hear later from you as well. We have a lot to cover in the next 75 minutes with 8 speakers. So I would really like to start with introducing the new director of the HIV, TB, hepatitis, and STI department in WHO, Dr. Tereza Kasaeva, and she will give a few opening remarks. Tereza, the floor is yours.
Thank you very much, Annette, and it's good morning, good afternoon, and good evening to colleagues and partners joining us from around the world. And our excellent moderator today, Annette, also demonstrate how dedicated are different people to this topic, and that double work in WHO is more than just a job. It's dedication, it's passion, and so following the needs of people. It's a pleasure to welcome you to this important global webinar launching WHO guidance for maintaining opioid agonist treatment as an essential health service. I would like to thank our partners at International Network on Health and Hepatitis and Substance Users and Médecins du Monde, our speakers also, and all of you for your commitment to advancing evidence-based, right-based responses for people who use opioids. The importance of OAMT cannot be overstated. It is not only a highly effective treatment for opioid dependence, it is also a very powerful tool for preventing HIV and viral hepatitis transmission, improving treatment adherence, and reducing avoidable morbidity and mortality. Where OAMT is accessible, well integrated, and uninterrupted, we see clear gains across the entire continuum of care. Fewer new infections, better retention in HIV and hepatitis treatment, improved TB outcomes, and stronger engagement with health services overall. Where OAMT services are disrupted, we risk losing hard-won progress in multiple disease areas at once. This is why today's guidance is so significant. It reinforces a simple but vital message. OAMT is not optional, not peripheral, and not a temporary intervention to be scaled back in times of crisis. It is a core, life-saving health service that must be protected and sustained during emergencies and during funding transitions. But OAMT is about far more than disease control alone. It embodies the person-centered integrated approach that is essential for universal health coverage. For many people, It is not just a medication, it is a gateway to comprehensive care, to mental health services, to HIV and hepatitis testing and treatment, to tuberculosis services, and to vital social support. By meeting people where they are with dignity rather than stigma, OAMT helps address not only medical needs, but also the broader social and structural determinants of health: exclusion, marginalization, and stability. Maintaining uninterrupted services on OAMT is ultimately about protecting lives, upholding human rights, and ensuring that people who use drugs are fully included in our health system. Dear colleagues, I look forward to the discussions ahead and to working together to translate this guidance into real and sustained impact. So once again, it's great pleasure and looking forward to the fruitful conversation.
Thank you so much, Tereza, for your wonderful words of support for and also in supporting the final publication of this important document, as you say. Our next speaker will give you an introduction on the document that we're presenting here, and it's a pleasure for me to introduce you, Anja Busse, who heads the department on drugs, alcohol, and addictive behaviors, or it's a team rather, within the Department for Mental Health and Substance Use. And I guess I'm getting all the terms a little bit wrong because things have changed since I left WHO. But this department guides the evidence-based policy and program support on substance use and addictions globally. So Anja will present the document here. So Anja, the floor is yours, the next 10 minutes.
Thank you so much, Annette, and also thanks for elevating us to a department, right? We wish we would be one.
Exactly.
Also, just want to thank everybody for joining today this launch event of this important new implementation guidance. And we will discuss here during the webinar how during emergencies like outbreaks, financial crisis, or health systems really face immense pressure, often disrupting essential health services such as, and this we will talk here, opioid agonist maintenance treatment with methadone or buprenorphine. These interruptions hit marginalized groups often the hardest, including people who use drugs and with drug use disorders. It was estimated for the year 2023 that about 61 million people worldwide have used opioids for non-medical purposes. That includes substances such as heroin, fentanyl, tramadol. Opioids account for most drug-related deaths, around 450,000 out of the estimated 600,000 deaths annually, often due to overdose and infections like HIV or hepatitis. Out of, in general, 64 million people living with drug use disorders worldwide, we know that only less than 10% have access to any form of treatment of drug use disorders, which is an additional challenge. So WHO recommends really a comprehensive approach to opioid dependence treatment. This includes, first and foremost, opioid agonist maintenance therapy, which we will call here OAMT, with methadone or buprenorphine. Opioid antagonists like naltrexone after withdrawal can also be considered, and psychosocial support. Naloxone needs to be available for emergency management of opioid overdose. WHO recommends, and I think that is important here, that OAMT should be used for most patients with opioid dependence, as it is the interventions for which there is the strongest evidence of effectiveness for a broad range of health and social outcomes, such as, for example, it can lower overdose risk, prevent HIV and hepatitis transmission, increase treatment adherence, reduce criminal justice contacts, and improve quality of life. Methadone and buprenorphine, as mentioned, the key medications here are life-saving medicines that are on the WHO essential medicines list. And as has been said, these are also essential health services and part of the universal health coverage packages. So in a longer term perspective, opioid agonist maintenance treatment really should be considered as a long-term solution for opioid dependence treatment. WHO emphasizes that treatment should be open-ended and continue as long as clinically indicated. Policies thus should allow for flexible dosing, starting low, maintaining higher dosage without limits on dose or duration. And those adjustments are gradual, and gradual reductions are possible, but the strength of OAMT really lies in its sustained and individualized and continued approach. Therefore, any dose reductions should be patient-driven, clinically guided, and need to ensure safety and effectiveness. So in cases of involuntary interruptions of OAMT, those first and foremost really need to be avoided at all cases. Because given the biopsychosocial nature of opioid dependence that often takes the course of a chronic health condition, patients with interruptions then might return to use. Involuntary or unplanned service interruptions, we need to take this into account, can be life-threatening. They can lead to withdrawal, to relapse, to overdose, and increase risks of HIV, hepatitis, and other health and social harms, and therefore must be avoided. So OAMT services really must plan to be resilient, including in times of crisis, which includes stock management and the preparation of a well-trained workforce. And I think we will hear some examples during the webinar. So also during crisis, uninterrupted OAMT must be ensured. Essential medicines such as methadone or buprenorphine should never be disrupted, and flexibilities in the import and export of controlled medicines such as these two should be used and explored. If interruptions are expected, again, contingency measures need to be implemented as early as possible to minimize potential negative consequences. Access to healthcare is a fundamental human right, and this includes people with opioid dependence wherever they are, in the community or in prison settings. OAMT should be prioritized like any other life-saving health service. Health system disruptions, such as those for which we have addressed and written the guidance, might include funding cuts, policy changes, emergencies. The COVID-19 pandemic comes to mind, and those can affect disproportionately vulnerable populations. So resilience is possible, and as said, adaptive strategies can be put in place. So if there are interruptions, for example, if NGOs have been providing OAMT before and through funding shortages cannot continue, there is a possibility to move that over to public health facilities, primary care providers, pharmacy, or even private clinics. And budget allocations are important, and ideally we really want to see OAMT integrated in national health budgets. People who use drugs have shown remarkable resilience during crises like armed conflicts or the COVID-19 pandemic. And to manage potential disruptions in OAMT, it's therefore vital to involve affected populations and provide clear and timely information to prevent further distress. Peer workers can support patients at treatment sites, while strong communication channels can enable rapid responses and overdose prevention actions. Training and harm reduction counseling, such as, for example, avoiding high-risk injecting behaviors, such as using a loan, are essential in this case. And a coordinated approach is overall needed among different stakeholders that include health, but also law enforcement and other key actors that might face a crisis with large groups experience withdrawal symptoms in case of OAMT interruptions. So among the mitigation measures that are discussed and recommended in the document is that when there are workforce shortages, but medication remain available, that expanding well-structured take-home doses for methadone or buprenorphine can be further considered, especially for stable patients and when there is a low risk of diversion. Take-home schemes have really proven effective during emergencies like COVID-19, when care was limited due to the social contact restrictions. So that's one of the recommendations, to really increase considerations for take-home. Another consideration in times of crisis and OAMT shortages is to consider and have good opioid overdose emergency programs in place. In this case, naloxone is recommended. It's an emergency medication that can reverse an overdose when given in time, an opioid overdose. And WHO recommends that people likely to witness an opioid overdose should have access to naloxone and be instructed in its administration. Naloxone is available in different formulations. Often the intramuscular injectable naloxone is cheaper, but it requires often additional training and laws to be in place to facilitate that. And Good Samaritan laws are considered here in special, that recognize that the risk of withholding naloxone is higher than the concern about allowing lay people to administer naloxone in case of an emergency. So naloxone is really a life-saving medication that needs to be available, especially during the times of crisis we are talking about here. Assisted withdrawal management is, in general, let's say, less recommended, because most people should be advised to continue opioid agonist maintenance treatment as possible, right? And the relapse will be lower. It's overall, we discussed the benefit. But when forced and abrupt opioid withdrawal occurs, including due to shortages of medications, and withdrawal is unavoidable, then it must withdrawal management must follow well-established protocols for pharmacological management of opioid withdrawal with psychosocial support that includes tapering doses. Also, methadone and buprenorphine can be used in withdrawal management, as well as other medications such as alpha-2 agonists, clonidine or lofexidine. And for patients that have completed withdrawal and might be motivated to really stop using opioids overall, there is also the possibility for naltrexone for relapse prevention. But keep in mind, this webinar is really on saying that most people should be advised to continue on OAMT as possible. So coming already to a closing of this, I also would like to highlight that psychosocial support and a variety of psychosocial interventions should be available according in times of crisis to support patients. Those can include counseling, evidence-based psychotherapy, but also assistance with social needs such as housing, employment, education, welfare, or legal problems. So, and in general, we have also seen that withdrawal protocols are more effective if psychosocial assistance is offered. So that might suggest that also in cases of unintended OAMT interruptions, psychosocial support really can play a role. Peer support, crisis management, all of this can help in addition to mitigate the stress linked with the crisis of not having access to life-saving medications. So here are again the key messages from the publication that we are very happy to launch with you today. WHO recommends opioid agonist maintenance treatment as the intervention to be offered to most patients with opioid dependence, and it must be maintained without interruption also during crisis as an essential health service. OAMT should be fully integrated into national health systems and not treated as an optional. If disruptions occur, early contingency measures are critical, and we discussed those. Communities have to be consulted, naloxone access has to be expanded, there can be reinforcing take-home dosages of methadone, buprenorphine, increasing psychosocial support, and the multi-stakeholder coordination. Abrupt dose reductions can be life-threatening. That's the other really take-home message here. And if withdrawal is unavoidable, it needs to be following established medical protocols. So with this, I just want to let you know that we are currently also updating the WHO guidelines on psychosocially assisted pharmacological opioid dependence treatment and the guidelines on community management of opioid overdose, and are merging those. And I think the first recommendations will be available by the middle of next year. With that, I thank you very much and hope you have access and can see the document now also for yourselves. Thank you so much, and over to you, Annette.
Thank you so much, Anja. And it wasn't an easy thing to summarize the document in 10 minutes. but well done indeed. I would like to move to our next speaker, who will be focusing on the impact of the foreign aid cuts. And you probably all know Anton Basenko, who is the executive director of the International Network of People Who Use Drugs, INPUD, and he is also a global advocate for the right and health of people who use drugs, drawing on lived experience and decades of harm reduction leadership. Anton, I hope you're ready.
Yeah.
You have 10 minutes. Yes, great. Thank you.
Thank you, Annette, and hello, everyone. Let me just start sharing my presentation. You see it well?
Perfect.
You hear me well? Okay. First of all, as Annette mentioned, I'm a person with lived experience. My drug use experience is more than 25 years, and I'm maybe close to 30. I stopped counting at some moment, but I'm one of the first opioid agonist therapy patients in Ukraine. My native country is Ukraine. Now I'm based in Belgium, and I'm speaking not only through my lived experience, but on behalf of the International Network of People Who Use Drugs, INPUD, and on behalf of the communities who lives with opioid, who are patients on opioid agonist therapy, or OAT. I would use this slightly different acronym, but not they use this therapy not as a policy preference, but as essential life-saving healthcare. And this message, which you see on your screen, put people first, but not for exclusion. We hear it very often. Sometimes it's even reflected in the names of the big conferences, put people first, put people first. But when serious shifts, economical shifts or political shifts are coming, somehow people who use drugs or people like OET patients, we are in the first line for exclusion. That's why I just extended this sentence, like put people first, but not for exclusion. And today my presentation is based on the data from our from our recent multi-language survey conducted in March earlier this year, which was launched also on the CND and this survey conducted during an acute crisis period following major US funding cuts. You all remember what happened, and it reflects the lived realities of people and organizations on the ground, not projections, not models, but immediate human impact, which we evaluated. So on this slide, let me begin with who this data represents. So we received 101 responses from across regions, acknowledging gaps in country coverage, but with strong representation from frontline actors. So 65% of respondents were drug user-led organizations, networks of people who use drugs. Another 22% were local civil society organizations providing harm reduction services, including OET, case management or support, and 13% were international NGOs or drug policy NGOs or even government partners. That matters because drug user-led organizations are often the first to see service disruptions and the last to be consulted when funding decisions are made. So the survey was conducted during this emergency moment, and what it shows is not a theoretical risk, but early warning signals of systemic collapse. So what are our 4 key takeaways from that survey? US funding cuts have cut harm reduction service at the knees. You can look at this table and compare top 10 services respondents implementing as organizations or have been implementing at the moment of that survey, and then the next you can see the top 10 service disruptions. So what services have been affected as a result of these funding cuts or received stop orders or other terminations. So So evidence-based harm reduction models, including OAT, are dismantled rapidly. And of course, you can see OAT in this list, especially in low and middle income countries. Without these services, sustaining HIV and hepatitis C responses becomes increasingly unrealistic. And also taking into account the general influence of progressive drug policies like harm reduction services on the lives of people who use drugs and their environment. Second, the impact has human face. And this is not about abstract budget lines. It is about people forced off treatment, peer workers losing jobs, clinics reducing hours, and communities facing rising overdose risk. Third, without peer-driven harm reduction services, the entire infrastructure of harm reduction is placed in jeopardy, and peer outreach is not an add-on. It is foundational to access, retention, and trust. And if you can see that the number one is outreach and peer-led harm reduction services, which has been disrupted. And those of us who are working in the field, we know that this is a basic element for the entire harm reduction model. Once you remove outreach and peer-led approach or peer-led approach, you cannot really implement the harm reduction model in its full. And finally, the fourth, these disruptions are happening at the exact moment when global commitments say put people first, but as the data shows, people who use drugs are being excluded from that promise. The data is clear, OET is being disrupted. Let me be very clear about what the data tells us. 63% of organizations report severe financial impact due to US funding withdrawal. Almost half lost 26 to 100% of their total budget. 23% lost between 3/4 to 100% of all their funding. And critically for today's discussion, 25% report reduced access to opioid agonist therapy. 43% report disruptions to needle and syringe programs. Disruption naloxone distribution, observed increased overdose death. And for women who use drugs, the impact is even more severe. 68% of services for women were reduced or halted. Peer-led outreach, which is essential for linking people to OET and keeping them in care, was also among the most disrupted services, as I mentioned earlier. And this is not accidental. Peer services are often the least protected in funding structures, despite being among the most effective. What OET disruptions look like in practice? Of course, when we talk about OT disruptions, we're not talking about minor inconvenience. It's also medication interruptions and reduced clinic hours, loss of trained staff and peer workers, increased risk of treatment discontinuation, heightened risk of overdose, HIV and hepatitis risk. And these disruptions do not happen in isolation. They interact with other stressors. For instance, emergency context. I'm from Ukraine. My country is 4th year in the war. We do remember how much we were struggling in the first stage of the war from the disruptions or risk of disruptions when Russians attacked my country and occupied certain regions or destroyed healthcare facilities which provide OET. But it's I'm proud to say that we not just survived, we stand strong, and we even increased number of OET patients in the country over the years of the war. But emergency context can be also natural disaster. Political factors, changes of the drug policy. Unfortunately, our friendly country, Georgia, which was one of the also pioneers and good examples of OET development in the region of Eastern Europe, Central Asia. Unfortunately, due to the latest changes in the, let's say, service delivery or drug policy approach, when all OET programs based on the private clinics has been closed, and the patients were proposed to go to the public healthcare facilities, but not all patients want or are able to do it. And there was, of course, some reason why they were using private clinics. So Among the others, procurement system reforms, transition of the source of funding, countries in the global fund transition, all this very well. Quality of drugs, recent case in Egypt also telling us that this can be a reason for disruption for certain patients.
You
I
have
mean,
1
disruption.
minute, Anton.
Oh, okay, okay.
1 minute.
Yeah, I'm actually, I'm on my last slide. So disruptions are not failures, not inevitable crises. And let me be clear, these OET disruptions are not inevitable. They are a result of all these reasons which you saw. But what needs to happen? Our call to action. INPUD's call to action is grounded on evidence, WHO guidance, which you just see, and lived experience. So first, for donors, funding agencies, emergency pooled funding mechanism must be established to prevent the collapse of harm reduction services, including OAT. And this is not about innovation, it is about stabilization. Second, for governments and policymakers, national governments must step in to sustain services previously reliant on US funding, and this includes protecting OET as essential health service, implementing social contracting models that prioritize community-led providers, removing legal and administrative barriers that delay OET procurement and delivery. And of course, innovations and long-acting forms of OET are very welcome and important, but only if those medications are not used as a repression or punishment measure. Third, for UN agencies and international bodies, emergency resource allocation must prioritize people who use drugs. And finally, for drug user-led networks and civil society, we must intensify advocacy, build alliances, and speak with one voice. So please use our report. QR code is on your screen. INPUD is planning to have a next cycle of this survey very soon to see the changes and reality of reduced funding for community as of now. And let me end where I began. ONT is not optional. It is not experimental. It is not luxury. It is essential medicine recognized by WHO, proven by decades of evidence, and relied upon by millions of people worldwide. When OET is disrupted, people die. When peer services are cut, people disappear from care. And when funding decisions ignore this reality, the cost is paid in human lives. If we're serious about ending AIDS, preventing overdose, upholding the right to health, then protecting OET continuity is non-negotiable. INPUD stands ready to work with all partners to make that happen, but the time for action is now. Thank you.
Excellent. Thanks so much, Anton. I'm moving ahead to our next speaker, Peter Vickerman from Bristol University, who will be focusing on the effect of service disruptions. Peter is a professor of infectious disease modeling at the University of Bristol, specializing in mathematical models that assess the impact of public health interventions on infectious disease transmission. Peter, you have 10 minutes. Thank you.
Are my slides showing fine?
Yes, perfect.
Okay. So today, I want to present some modeling we've been doing in collaboration with people from INPUD and the Harm Reduction International, looking at the impact of service disruptions in needle and syringe programs and opioid agonist therapy on HIV and hepatitis C transmission amongst people in check drugs. And this was done in light of the PEPFAR cuts, but also other reductions in global funding that have been occurring recently. Okay. Oh, it's okay. So we all know that people in check drugs have a disproportionately high burden of HIV and hepatitis C. And we all know that there's good evidence that opioid agonist therapy and needle and syringe programs reduce HIV and hepatitis C transmission. Now, the US government funds a large share of these services, or they used to, particularly in low and middle income countries. However, recent disruptions in US government funding, but also other global funders, and specifically PEPFAR, is likely to cause problems in the provision of these services, ceasing activities for opioid agonist therapy in some settings, and also disrupting needle and syringe program provision, even though PEPFAR and US agencies don't fund needles and syringes, but they do fund the base, the foundation which these services are built on in many settings. What we wanted to do was to evaluate the impact of reductions in opioid agonist therapy and needle and syringe program provision on HIV and hepatitis C transmission. And specifically in this analysis, we considered 9 countries where PEPFAR funds opioid agonist therapy. So we developed a static mathematical model to look at the short-term impact of disruptions in PEPFAR funding for opioid agonist therapy and needle syringe programs. We firstly estimated the proportion of people inject drugs that were receiving PEPFAR-funded OAT and the proportion of needle and syringe program provision that could be disrupted from PEPFAR funds, reduction in PEPFAR funds. We then use that data within the model to estimate the number of added new HIV and hepatitis C infections that could occur over 1 year due to those disruptions. The model was parameterized to the 9 countries shown in the map on the right, with most of the countries in sub-Saharan Africa except for Ukraine, Kyrgyzstan, and India. For each country, we use country-level data from systematic reviews to parameterize it, including data on the population sizes of people who inject drugs, their HIV and hep C prevalence, their incidence levels, the overall number of people who inject drugs, accessing needle and syringe programs of opioid agonist therapy, and evidence on the effectiveness of those interventions in reducing HIV and hepatitis C acquisition. We also use data to estimate the magnitude of the disruptions in needle and syringe programs and opioid agonist therapy. So this was a little bit more tricky for needle and syringe programs. We used data derived from the survey that Anton was discussing in his presentation. So this survey was given to 101 organizations and 51 countries of harm reduction service providers. And we used data from 4 questions that they asked in that survey. First, we looked to see whether an organization reported providing needle and syringe program services, and if these needle and syringe program services or harm reduction supplies had been disrupted due to funding cuts. We then used information from 2 other questions. We looked to see what percentage of the organization's funding came from US government sources and the percentage extent to which funding cuts affected those services. We used answers to those last 2 questions as proxies for potential reduction in needle and syringe program access that occurred amongst people who inject drugs in 2025. For OAT, we used PEPFAR data on a number of people who inject drugs on PEPFAR-funded opioid agonist therapy in the past 6 months in 2024, and that was given at the country level. We used that in a model to estimate the number of people who inject drugs on PEPFAR-funded opioid agonist therapy at any point in time in 2024 using country-specific retention estimates. These estimates were used to give us an idea of the number of people who inject drugs that stopped using or stopped accessing opioid agonist therapy in 2025 due to the cuts in PEPFAR funding. So, in terms of opioid agonist therapy coverage, the map on the right shows the coverage of PEPFAR-funded OAT in the 9 countries where they provided it and where we modelled. Overall, in those 9 countries, we estimate that the coverage of opioid agonist therapy was 3.3%, or just over 46,000 people inject drugs. This coverage is low and varied across the different countries, from less than 1% of people inject drugs being on opioid agonist therapy up to 13.5% of people inject drugs. Of those people on opioid agonist therapy, from looking at the PEPFAR data, we estimated that just over 40,000 was on PEPFAR-funded OAT, which is 87% of the overall provision in those 9 countries. In terms of needle and syringe program coverage, that was a lot higher in the 7 countries of the 9 that had data. We estimated in those 7 countries that 48%, or 730,000 people inject drugs, were accessing needle and syringe programs in the last year. This coverage is much higher than the coverage of OAT, and as with OAT, there's heterogeneity across the countries. Looking at the INPUD survey, we estimated across those 7 countries, an estimated 16% of needle and syringe program provision had been disrupted due to US funding cuts, estimated at 119,000 people inject drugs. So on this figure, we present the increase in the number of new HIV and hepatitis C infections over 1 year due to the disruptions in PEPFAR-funded opioid agonist therapy and disruptions in needle and syringe programs over 1 year. So if you look on the figures on the left, you see that we have estimates for the overall number of additional infections and then the number of additional infections for different countries in a descending order. Overall, we estimate that the disruptions will have resulted in about 3,600 new HIV infections and 6,500 new hepatitis C infections in 2025. The largest impact we estimate for HIV will be in South Africa and Ukraine, of the countries that we modelled, and for hepatitis C will be South Africa, Ukraine, and India. Most of the impact of the disruptions in our projections is due to the interruption in needle syringe program provision, which is contributing about 3/4 to 80% of the overall impact. And that is due to the much higher coverage of needle and syringe programs compared to opioid agonist therapy in these countries. Indeed, when you look at the impact per person stopping each of those interventions, we find quite similar impact for opioid agonist therapy and needle and syringe programs. Indeed, for one additional HIV infection will occur per year for every 55 people that stop accessing opioid agonist therapy, or 41 people stop accessing needle and syringe programs. For hepatitis C, these estimates are lower. So for each one additional hepatitis C infection will occur per year for every 23 people stop accessing opioid agonist therapy, and 24 stop accessing needle and syringe programs. So the last slide looked at absolute impact. If we now look at what is the likely relative increase in new HIV and hepatitis C infections, we estimate that they will have increased by about 8% in the 9 countries that we modeled due to the disruptions in OAT and NSP. When we look at the impact of just the disruption in OAT, we find that's much smaller, about 1.4% relative increase in new HIV and hep C infections. When we look at the 7 countries where there was disruptions in the opioid agonist therapy and needle and syringe programs, we find the impact was a lot larger, though, about 17 to 19% relative increase in new HIV and hep C infections. This figure shows the relative increase in infections for the different countries, showing that Ukraine, Kenya, Tajikistan, and Kyrgyzstan would have had the largest increase in relative number of HIV and hep C infections, and that's because they either had higher levels of OAT provision or higher NSP disruptions based on the input survey. So why is the impact of the OAT disruptions low? And the main reason is the coverage of OAT was low before the disruptions. In those 9 countries where PEPFAR was funding OAT, we estimated that only 3.3% of people who inject drugs were receiving opioid agonist therapy. And this is globally relevant to the rest of the world. If you look at the map on the right, that's from a systematic review in 2023, which found that 84% of countries globally had no or low coverage of opioid agonist therapy, defined as less than 20% coverage amongst people who inject drugs. And this doesn't mean that opioid agonist therapy doesn't work. It's just because of the low coverage. And when we've modeled the impact of opioid agonist therapy, we find that if you scale it up, it can have a large effect in decreasing HIV and hep C incidence. Also,
Peter,
our projections are...
Yeah, I'm sorry, you have to come to a close.
Okay.
Yeah.
All right. Sorry. So yes, basically, this funding suspensions do threaten provision of opioid agonist therapy and harm reduction amongst people who inject drugs. However, the opioid agonist coverage is low, so the detrimental impact may not be great. This emphasizes that we need to not only replace PEPFAR funds, but we also need to diversify and increase funding to increase the coverage of OAT, which has always been historically low. And this needs to be increased going forward. Thank you.
Thank you so much, Peter. And sorry for interrupting, but we have a tight program. Very good to see these direct impact figures. Next, we're moving to a case study from Skoun in Lebanon, presented by Tatyana Sleiman, who is the executive director of Skoun Lebanese Addiction Center, based in Beirut. It's a harm reduction and addiction treatment organization and a long-standing advocate for equitable, right-based drug policy and mental health support. Tatyana, please take the floor.
Thank you so much, Annette, and hello, everyone. So I will share my screen. Can you please let me know if you can see my slides?
Yeah, can you put it in presenter mode?
Yes?
Yes, perfect. Yeah.
Yes? Okay. All right, so hello, everyone. And so as Annette said, I work with Skoun in Lebanon, which is a harm reduction center and a treatment center that's been operating since 2003. And basically, the case study that I will be presenting today it's actually an overview of the situation that we had between 2021 and 2022. But first, I want to give just a general background about the opiate agonist maintenance treatment in Lebanon. So it was legalized in 2011 and made available in 2012 as a public health response in Lebanon. The OAT program is managed by the Ministry of Health and particularly the Narcotics Department in the Ministry of Health. And we have a quite complex way of managing and dispensing the OAT program. So first of all, the medication that we have is only buprenorphine or the combination of buprenorphine and naloxone. So we don't have methadone in Lebanon. And the Ministry of Public Health is the main agent that oversees the procurement through one pharmaceutical agent that is accredited to procure the buprenorphine. And then there's a whole protocol that needs to be followed for people or service users to be able to access the medication. So it's only housed at the time of the crisis that we had in 2021. It was only the medication was housed and dispensed through 3 governmental dispensaries. So they are pharmacies that are housed within governmental hospitals that are accredited by the MOPH. And then to be able to receive the medication, you need to get your prescription from a psychiatrist. And the psychiatrist also needs to be accredited by the Ministry of Health. So has to go through a training and an accreditation process by the Ministry of Health to be an OAT prescriber. So it's not any psychiatrist. And it's not any center. So these psychiatrists are not available in public hospitals or primary healthcare centers. It's usually either through non-governmental organizations that also need to be accredited by the Ministry of Health for OAT prescription or private clinics, private psychiatric clinics. So it's quite a complex process. You cannot access the medication unless you are doing periodic urine tests, you are seeing a psychiatrist, you are also mandated to be seeing a therapist or a caseworker to be able to access the medication. At the time of the crisis that we had, the disruption, there was around 1,000 people who were registered in the OAT program nationwide. And so the context of the crisis itself, so for those of you who are not very familiar with the Lebanese context, since 2019, the country started going into a gradual economic collapse for various reasons related to state corruption, mismanagement of money, which eventually resulted in a devaluation of our Lebanese currency. So at the time of the OAT crisis in 2021, the Lebanese pound was already devaluated compared to the dollar because it's pegged to the US dollar by 90%. Of course, as add-ons during that period, we had the COVID-19 spillovers, but also the Beirut port explosion spillovers, which had really put the country in a humanitarian emergency situation, also ongoing political instability. And then because of the economic crisis, we had a shortage of medication across the board in Lebanon. So it was not just the OAT or the buprenorphine, but because the central bank was not able to pay pharmaceutical agents to subsidize the difference in the prices for the medication. And at the time, the Ministry of Health still had the registered price of the medication on the old value of the Lebanese pound. So it was impossible to import and export medication and then to sell it at the price of the devaluated lira. So we had a shortage across the board. But the problem with the OAT is that we were notified about the shortage by the Ministry of Health at a time where the whole stock of medication that was left in the dispensaries could barely last for a month or a month and a half based on the current usage of people who are on the treatment program. So we had very little time to act as a collective. The main mitigation measures that we went through, well, first of all, we formed a coordination body because on paper, we did have a OAT task force, but it had not really been active since the OAT protocol was launched back in 2012. So we had to reactivate this task force, which was mainly set up on an ad hoc basis. It was, WhatsApp meetings, WhatsApp phone calls, weekly meetings that were happening to try to address the emergency. And it was mainly made up of the CSOs that were dispensing the prescriptions, the governmental pharmacies, the Ministry of Health, represented by two bodies, which were the Narcotics Department and the National Mental Health Program, and then the Lebanese Psychiatric Society and the specific psychiatrists also that are accredited to dispense the medication. One of the first things that we had to do was as a collective, was to agree on reducing the dosages that people were accessing. So a very tough decision had to be made, which was to reduce the dosage for everyone to 8 milligrams per day for a specific period of time, so that we can retain the stock of the medication available as long as possible until we are able to find solutions to import new stocks. A decision was also made by the Ministry of Health to not enroll new people, so not register new people on the OAT program during that period. At the same time, the pharmaceutical agent had expired medication in stock. Usually what remains as expired, they usually return it to the manufacturer and then get a replacement. But at the time, since this was not possible and the medication was only expired for 2 or 3 months, the Lebanese Psychiatric Society actually issued a letter stating that they are capable of prescribing this medication and it would still have effect. And the ministry approved this, and then we had to make service users it was their choice to sign consent forms to be able to access this expired medication. At the same time, across the board, we were increasing the mental health support and the psychosocial support to the service users themselves, but also to their families, their spouses, their partners. We were working to secure donations so that we can have an increased stock of the medication. And through, our work as CSOs, we were able to secure cash donations to be able to pay the pharmaceutical agent to procure a new stock ASAP. And at the same time, we were able to secure a donation of the medication itself through Etifarm. It was Esprenor at the time that we were able to receive a donation and then distribute it for free for a specific period of time to the people that were already enrolled in the program. Some people during this period, because of the withdrawal symptoms, because they were not sure when the medication will be available again, will it be completely interrupted, at which price they will be able to get it once the subsidies are lifted, decided that they wanted to go into detox programs, inpatient detox programs, so that they are able to stop the OAT altogether. So we're also able to cover and support the cost. Because also none of the services related to substance use in Lebanon are covered by the state. So the buprenorphine itself, people have to pay for it. And the services related to drug use, whether it's inpatient detox or outpatient services, everything is paid unless it's supported by a CSO. Also during that period, we had to procure a batch of naloxone because it was not available. And we also made like an emergency distribution of naloxone to people because we knew they were at higher risk of overdoses. And psychiatrists also issued a unified protocol to prescribe psychotropic medication to be able to manage, first of all, the anxiety that came from all of the situation, but also the craving and the withdrawal at the time. So briefly, the direct impact during that period on the service users. So obviously, increased stress, increased anxiety, fear of public withdrawal because of, stigma and criminalization. A lot of people in Lebanon who are on the OAT program don't really disclose this to their employers, to their spouses, etc. So there was a lot of fear at the time to, lose jobs and have family problems. There was family distress also around the persons who were on the OAT program. The only positive note that we could highlight during that period, and we believe it was really due to the intensive support that was given to people on a psychosocial level, was that we did not have any reported overdoses due to this shortage. So general reflections, I know I still have 1 minute. So general reflections post the emergency, which of course was highlighted already by my colleagues, which is the need for flexible procurement processes. At the time, we were already in an emergency, and there were a lot of agencies that were procuring a wide range of other medication. The only reason they were not able to help us procure buprenorphine at the time was because of the layers and layers of complexity to be able to procure a controlled substance. Of course, the cross-sectoral collaboration between public health, community groups, mental health agencies, harm reduction actors was essential, and it was something that we were able to build on later on in 2024 when we had the war on Lebanon, because also there were disruptions in access to OAT, and this foundation that we built in 2022 really helped us to address these disruptions 2 years later. Of course, the recommendation to decriminalize drug use and personal possession remains a top priority, because a lot of the disinvestment that we saw in how to manage the stock during the emergency and how to be prepared for the emergency comes also from the deprioritization of people who use drugs in general. Securing multiple medication sources also, the fact that we had one pharmaceutical agent at the time and only one type of medication that was procured kind of made things more difficult for us to be able to access a new stock of medication and register a new stock of medication. And now these things are changing, along with the integration of services for people who use drugs, including the OAMT, into public health care and into state responses and into emergency responses moving forward. So I guess this is it. Thank you so much. You're on mute, Annette.
I'm on mute. Thank you very much indeed, Tatyana. That was an excellent example. Yeah, we have to move on. We're running over a little bit, which will eat into our question and answer session. But please look in the Q&A, because a lot of your questions are already being answered. So without further ado, I'd like to go to our final speaker before the closing, Michel Kazatchkine, who will be focusing on the broader drug policy context. As you all may well know, that Michel is a physician, a diplomat, and a global health leader with decades of experience addressing HIV/AIDS and harm reduction, including as the former director of the Global Fund, as UN Special Envoy for HIV/AIDS, and he is a founding member of the Global Commission on Drug Policy. Michel, the floor is yours.
Thank you very much, Annette, and good morning, everyone, and thank you for this opportunity to address the webinar and make a few points. Well, first, congratulations to WHO and to everyone in the drafting and the editing team. I believe this is a significant and far-reaching document, and we at the Global Commission welcome the document, as we have consistently advocated for drug policies to prioritize health and expand access to evidence-based treatment to all those in need. The statement in the document is unambiguous. WHO recommends that OAMT be used for most patients with opioid dependence, as it is the intervention for which there is the strongest evidence of effectiveness for a broad range of health and social outcomes. This may be like stating the obvious for a number of the professionals on this particular call. But as we saw from some of Peter's slides, it is still so distant from public health policies in many, if not most, parts of the world. My second point was already addressed, is that treatment gap is huge. 50 to 60 million people globally are estimated to live with opioid-related drug use disorders, with fewer than 10% having access. Actually, fewer than 1 in 5 people in need access treatment in the US, according to NIDA. And coverage with OAMT is less than 5% in most countries in Eastern Europe and Central Asia, where the HIV and hepatitis epidemics are still expanding and remain largely driven by unsafe injection drug use. Third, OAMT. Each of these four letters is important. M here is for maintenance. And maintenance to me means maintaining treatment as long as needed. And maintain also means maintain people in good health and fully integrated in society. The T is for treatment. But as we've been hearing, OAMT is also part of an effective harm reduction intervention complex, protecting people against overdose, against HIV and hepatitis C, and against the harms associated with the need of procuring illicit opioids every day. And the scientific evidence of the effectiveness of harm reduction is compelling. The HIV community has understood it and endorsed harm reduction from the start. So harm reduction, including OAMT and its funding, have long been confined to national and international HIV programs, which I think has also led to some misunderstandings in the public health community and, I would say, neglect of OAMT among the conventional addiction treatment and mental health community. So my fifth point here is that it is time for the addiction treatment community and the mental health community to take full ownership of OAMT and close the treatment gap. This includes licensed addiction treatment programs in the US and the broad community of so-called narcologists in Eastern Europe. Next, as discussed, OAMT should be fully integrated in national healthcare systems. And as the document states, national strategies should include a clear outline of government policy to ensure adequate coverage, quality and safety of treatment, including methadone, buprenorphine, long-acting buprenorphine, and we would argue also heroin-assisted treatment when needed. COVID has shown that delivery of methadone and buprenorphine does not have to be as stringent as it currently continues to be in many countries. So I welcome the sections on the take-home doses and on the role of communities in facilitating broad access to OAMT. Next, methadone and buprenorphine are on the WHO model list of essential medicines, but still not on many national lists of essential medicines. And this raises issues of both access and cost. I have seen many examples of expensive methadone because it is imported by a single, non-competitive, monopolistic procurement channel. This is the case in South Africa, and we just heard from Lebanon. And also, there is no need to import methadone in an expensive liquid form, as I've recently understood it is the case in Afghanistan. Generic methadone is available in tablet, concentrate, and liquid versions for several different manufacturers. And there are generic forms of buprenorphine, widely available as tablets and films, often combined with naloxone. So I would like to take this opportunity to call, as a follow-up of this guidance, for a major effort of WHO and partners to expand regional and sub-regional manufacturing of OAMT medicines, just as in other areas of medicines, we call for more decentralized manufacturing of medicines, diagnostics, and vaccines. And my final point, OAMT is the intervention for which there is the strongest evidence of effectiveness. However, as the guidance also states, OAMT is one component of a holistic approach to care of opioid dependence, an approach that addresses not only individuals' drug issues, but other areas of his or her life, including mental health, housing, employment, all issues that are better addressed when people are on maintenance therapy. So if we are to stand any chance of reaching our targets of UHC and to reduce overdoses, HIV and hepatitis transmission among people who inject drugs, we need, as an international community, to further open up the debate and fundamentally change our ways of thinking, our policies. It's no longer sustainable or credible to pretend that the current reliance on drug law enforcement is effective. People struggling with drug abuse or addiction may harm themselves and their families or communities, but criminalization and social marginalization will not help them. One cannot impose health or solve drug-related social problems through a war on vulnerable people. Treating problematic drug use and dependence is a key responsibility of governments, not just a moral obligation, but one defined within international drug law and human rights law and backed by scientific evidence. Thank you.
Wonderful. Thank you so much, Michel. I also wanted to thank you personally for motivating WHO to stress this message around OAMT being the most effective form of treatment for most people with opioid dependence, which, because of our very successful advocacy around harm reduction, sometimes got not completely understood in many places. So it's also in a big way thanks to you that we have been able to develop this document and include this important message.
Thank you to you, Annette. Yeah.
Well, thanking just before coming maybe to one question, given the time that we have left, I would like to thank a few more people who have been really critical in the development of this document, such as Ernst Wisse from Médecins du Monde, who, as a consultant to WHO this year, has actually helped writing this document, and former colleagues Nicholas Luhmann, who and Dmitry Krupchanka, who is still in WHO. Nicholas and I are no longer, and of course Anja, who you've heard today, and Anton's, Mozelewski's. So just wanted to mention a few of these. A lot of the questions have been answered in the Q&A, and they have to do with OAMT and further details around it. I just want to remind you again of the fact that WHO is in the process of updating the OAMT guidelines. So a lot of your topics and questions will be addressed in those. And I think around policy, and Michel also summarized all this very eloquently, and it's been addressed in many of the comments, are political, financial, etc., in order to scale up and secure OAMT, which of course we cannot really solve with this webinar or with this document. But I hope that everybody involved in improving access to this life-saving form of treatment can use this document in your efforts and in your advocacy, and work with governments to make the case for the importance of this document and the recommendations made in it. So there were a few topics, and basically there is not really time to answer, but maybe very quickly we could go to Tatyana, Skoun. There was a question of whether you have considered the introduction of long-acting buprenorphine for patients in Lebanon. We don't have a recommendation yet as WHO, but we have, of course, this project that we do with Unitate. I'm saying we, as you know, because I'm still feeling part of WHO, but where this form of treatment is being piloted. But perhaps Tatyana, would you want to say something in 1 minute around this?
Yes, absolutely. Thank you, Annette. So basically, during that period or shortly after, there was the Buvidal, which is the 1 month injection that was registered by the narcotics department. But the process again for the protocol for dispensing is not yet finalized. And again, one of the barriers remains, so even if this medication is available, and of course some people will be able to benefit from it, the barrier remains the price, because it's obviously more expensive and because it's not covered by the state, so people will still have to pay for it themselves. It will not allow access for many, many people who would need it. But it definitely did spark this, the shortage definitely did spark this conversation. And we know that the medication has been registered within the list of medication within the Ministry of Health, but it's not yet available or being dispensed because the protocol has not been agreed upon yet.
Thanks a lot, Tatyana. I also would like to just highlight a comment from Matt Southwell around the role of peer workers, because they're key in access and engagement of people with opioid dependence into treatment. And that is something that, of course, Matt, you are dedicating your work and life to, and just want to highlight this, and also the fact that we can probably do more about the education and training of peer workers to support OAMT. Not something we can easily respond to now, but it's a critical point. So thanks for making that, Matt. Finally, I would like to move to Dr. Tereza Kasaeva from WHO. She is the director ad interim of the Department of Non-Communicable Diseases and Mental Health. And she will give some closing remarks by video. I would like to, before opening the video, just to shortly thank everybody, all the speakers, but also all the people attending. I think we were close to 200 people, for your dedication and support. And I hope everybody can continue the good work. So thanks again, and thanks to INSU and MDM and WHO for organizing this, this webinar and allowing me to chair this. Please, you can show the video.
Hello, and thank you to all organizers, speakers, and participants for your contributions today. This webinar has underscored the vital role of opioid agonist maintenance treatment, OAMT, as a proven life-saving intervention that reduces mortality and supports health and stability for people who use opioids. The WHO guidance we presented today provides clear, practical recommendations to maintain uninterrupted OAMT services even during emergencies, whether conflict, crisis, or funding disruptions. Service continuity is not optional. It is essential to prevent overdose, protect health, and uphold human rights. We have heard evidence and experiences showing that integrating OAMT into national health systems strengthens resilience and sustainability. This is about equity and inclusion, ensuring that people who use opioids are not left behind, even in the most challenging circumstances. As we conclude, I urge all of you, policymakers, providers, community organizations, and people with lived experience to use this guidance and advocate for uninterrupted OAMT as part of comprehensive health services. Together, we can save lives and advance health for all. Thank you.